Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Hello, I'm today's host, Dr. Lauren Wynand, and welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily. These experts provide their opinions, insights, and commentary on the leading topics and issues in medicine, focusing on specific disease states. Today's podcast will focus on chronic lymphocytic leukemia with Dr. Ian Flynn from One Oncology and Tennessee Oncology. Dr. Flynn, would you like to introduce yourself?
Yeah, hi everyone. Ian Flynn from One Oncology and Tennessee Oncology. I'm a clinical investigator and clinical researcher in the area of chronic lymphocytic leukemia and lymphoma.
Thank you. And Dr. Parikh, would you like to introduce yourself?
Yeah, hi. Thanks, Dr. Wine, and hi, everyone. Thank you for having me. My name is Samir Parikh. I'm a hematologist at Mayo Clinic in Rochester, Minnesota, and I focus on CLL as my clinical and research interest, and I'm happy to be here. Thank you.
Thank you, Dr. Parikh. And last but certainly not least, Dr. Carrie Rogers from the Ohio State University College of Medicine and Comprehensive Cancer Center. Dr. Rogers, would you like to introduce yourself?
Sure. I'm Carrie Rogers. I'm a hematologist at Ohio State, and I'm an associate professor at The Ohio State University. My clinical research interests include chronic lymphocytic leukemia and hairy cell leukemia. I have a special interest in autoimmune cytopenias.
Excellent. Our first topic for today is management of double-exposed and double-refractory patients with chronic lymphocytic leukemia. We'll start with you, Dr. Flynn. The question is, what is your approach to the management of double-exposed and double-refractory patients with CLL?
One of the non-covalent inhibitors, the only FDA-approved one now is pirtobrutinib, but we hope we will see others in the future. So I think that's a great treatment option. I often get profile for these patients in terms of their mutational status of the BTK, such as cysteine 481 mutations or other mutations. Although I think it's worthwhile trying pirtobrutinib in a variety of settings, pretty much all those, even if they don't have one of those mutations. Beyond that, I think we're then going into things like combinations of known agents.
Up until very recently, with the accelerated approval of both pirtobrutinib and liso-cel, the CAR-T product, we didn't have approved drugs that were expected to work well in this case. And by well, we're talking about, like a median of 1.5 years with pirtobrutinib. I mean, there were things like idelalisib, but responses were not overly good. And so the strategy that Dr. Flynn was discussing with covalent BTK inhibitor and venetoclax, we published our data at our institution that you can get durable benefit, but relapse after that is usually very difficult to control when the cells have become resistant to the combination in that setting. Also, I similarly have absolutely no idea why that works, but it does. So that is really where you need to think. If you have someone who's younger, are you going to send them for an allo transplant? Are you going to send them for CAR-T? And with liso-cel, you're seeing about 18%, which is a little less than 1 out of 5 patients really get that undetectable disease with what we think is going to be a long-term benefit, meaning the bulk of patients actually won't end up with, disease control for the remaining lifespan from a CAR-T. So you have to think about talking to people seriously about what you might do.
I do think that, being able to sort of say I'm done with treatment is an important thing for many of our patients. However, we know that patients with del17P, those who have bulky lymphadenopathy and those that have unmutated IgV8 genes, in multivariate analysis, these 3 factors were shown to be associated with a shorter progression-free survival in the CLL14 study. So there's, certainly a subset of patients where we will not expect to see a durable progression-free survival or durable duration of response from this therapy. And I think that's really where, at least for the last, decade or so, there have been a lot of approaches to improve upon this with combinations consisting of a covalent BTK inhibitor and venetoclax. Unless we have more data for the triplets, and their safety, we should not be using them in the clinic. Only in the context of a randomized trial, they should be used. And I think to answer your question about what I'm most excited about, I think it's really the doublets with covalent BTK inhibitors and a BCL2 inhibitor in the frontline setting.
Fantastic. Thank you, Dr. Parikh. Dr. Flynn, what are your thoughts on this topic?
Yeah, I really agree with Dr. Parikh on this. It's not obvious to me that one regimen's better than the next, and I tend to want to go with a 2-drug regimen over a 3-drug regimen at this point until we know better. I think the combinations of covalent BTK inhibitor with a venetoclax or another BCL2 inhibitor are really quite exciting. The whole notion of having all oral regimen, I think, is appealing to patients by having a lead-in. You can often, with the BTK inhibitor, you can often reduce the risk of tumor lysis syndrome, making it easier to give that regimen.
Great, thank you guys. And our final topic for today is challenges in the diagnosis and management of accelerated chronic lymphocytic leukemia, or Richter's transformation.
So it can be hard just because you actually have to get a biopsy or a tissue sample. And then also there's a risk of missing the thing that's actually the second pathology there in someone that has CLL. So, I mean, there's lots of things you can do to try to help with this. PET scanning is a really important one to try to make sure you biopsy more metabolically active areas. Getting an excisional lymph node biopsy whenever practical, I think is really important, because then you can get the tissue architecture of the whole lymph node to see if there's just CLL and something else, etc. These days, it's been very popular to just get interventional radiology to just put a needle in something and then get a diagnosis. And I don't want to minimize how nice that is for our patients and what an important tool it is. But when you do a core needle biopsy, or even worse, an FNA, you may not actually get a diagnostic sample for something like Richter's, you might get a diagnostic sample of what you knew they had, which was CLL, and not a diagnostic sample of like the second pathology, which is really what I'm talking about. So I think that's a huge challenge. And then Richter's, of course, is a variety of lymphoma pathologies, right? So Richter's is like the common terminology for lymphoma in a CLL patient, but you can have Hodgkin's Richter's, DLBCL Richter's, and then the whole spectrum of different diffuse large B-cell lymphomas. So I think, trying to make sure you have like the right information about the second lymphoma is key. So I think actually just making the diagnosis is one of the hardest challenges. And layering on that, just one last thing is, especially with Richter's, people can be quite sick. So you can have some very severe constitutional symptoms. So getting a diagnosis that's accurate is urgent, because you need to start some sort of anti-neoplastic treatment. And it's extremely hard to do that when you don't know what the neoplasm is. And CLL treatment is not expected to resolve, Richter's at least. So I think those are like the main challenges, at least I see.
There's just so much in with respect to the diagnosis of Richter's transformation, whether it's be large cell lymphoma, accelerated CLL, Hodgkin lymphoma. I think we really don't understand it fully, and I think there's a lot more that needs to be done. And I think, to the extent that, and I know that there are now efforts going on in the international community, led by the European Research in CLL, the ERIC consortium, trying to put together a white paper for Richter's. And I think that is going to be huge, because I think it's a very different disease process. Patients with CLL, once they, unfortunately develop this complication, have a very different outlook. Unfortunately, the survival isn't the best. It's like typically, despite everything that has been done, still less than 1.5 years, max 2 years. And I think those are, the patients that really need a concerted effort from people across the globe to be able to make meaningful improvements in outcomes.
As Dr. Rogers mentioned, there's multiple different types of Richter's transformation. But if you look at the large cell transformations, there are sort of two: the clonally related and the non-clonally related. And the non-clonally related tend to do much better than the clonally related, albeit it's very challenging outside of academic university settings to figure out one versus the other. And so clinically, you're sort of forced to treat both. The outcomes, unfortunately, for the vast majority of patients with Richter's transformation are horrible. We try standard regimens for large cell, which is R-CHOP or R-CHOP-HOLA, and to date, that really haven't moved the needle very much there. We're also talking about accelerated CLL. I think that's a relatively new sort of recognition. In the old days, we would just say that's really bad CLL, and now we sort of lump it together. I don't think we're all that good about knowing how to treat that either. I mean, they tend to just use the next available regimen for CLL, for regular CLL, although the duration of remissions are a lot shorter there. So a lot of room for improvement in all these different transformations, but today still very challenging diseases to treat.
Thanks so much, Dr. Flynn, Dr. Parikh, and Dr. Rogers for sharing your expert insights with us on these important topics for double exposed and double refractory chronic lymphocytic leukemia and accelerated chronic lymphocytic leukemia and Richter's transformation. And thanks to our audience for tuning in. We hope you found this podcast to be valuable for your practice, and we look forward to having you join us next time.